So first of all, thanks a lot for having me on this phone call. And I'm really excited and proud of what you guys are doing on your own initiative in terms of developing this trainee group for CAPER. So, so just from the offset, I just want to let you know that I'm really excited about this, and we'll talk more a little bit about the future of CAPER and where I think you guys and hope you will play a role. But so I am, so as Peter had mentioned, I'm an assistant professor now at Stanford, and I've been, I started my GI fellowship in 2006 and finished in 2009. And so I've been out of fellowship for a little over 8 years now, just a little under 8 years. I started out as an instructor for 3 years, and then became an assistant professor at Stanford shortly thereafter in 2012. I do endoscopic ultrasound. I did not do a therapeutic fellowship. I happened to be at the right place at the right time, where during the third year of my fellowship, we did not have a fourth year fellow. And my fellowship was a research fellowship in that most of my clinical work was completed in the first year of fellowship, and the latter second and third year, I was on a T32, which essentially protected me from clinical work. I was limited to 1 day of clinical work, which amounted to a half day of continuity clinic and a half day of endoscopy. And it was during those 2 years that I started developing an interest in the pancreas. But it was relatively late. It was not until the third year, near the third year of my fellowship, I started out my research component in my GI fellowship, focusing less on a clinical focus, but more on some type of research methodology. And I ended up, with the support of my fellowship, doing a master's in health sciences research, which is similar to a master's in epidemiology. And I worked with some good mentors who were not gastroenterologists, but were health economists. And I was really interested in the costs of device technology, particularly as it pertained to GI. So, I had come to the realization that if I wanted to succeed academically, unless I was really in wet lab research, being a clinical researcher, it would be a very difficult path to forge a research career strictly on an interest in technology assessment in GI. There were very few people who were successful at doing that, and I felt that I needed a niche, a clinical niche. And during my continuity clinic, I had started to see patients with chronic pancreatitis and pancreatic cysts. And at the same time, I had just fortuitously gotten along very well with the head of our therapeutic endoscopy group, Dr. Jacques Van Dam at the time, who's no longer at Stanford. But having no therapeutic fellow, he had invited me to do EUS and ERCP as part of my third year training. I had chosen not to do ERCP, but I did take up EUS as my interest in the pancreas grew. So my third year of fellowship, as I was concluding my master's, I started developing a strong interest, a clinical interest in medical pancreatology, and I did complete my training in endoscopic ultrasound, but not ERCP. And near the end of my third year, my division chief understood that I was interested in the pancreas. At the time, that was Jay Pastricha, who's now at Hopkins. And not having an actual faculty member at Stanford who had kind of focused on medical pancreatology, I ended up, with the division support, spending 2 months as an away rotation at the Mayo Clinic with Suresh Chari and the pancreas group to kind of formalize some training in pancreatology. So with that training in mind, I started out as an instructor at Stanford. at Stanford, there are 3 different faculty tracks. And on one level, there is the research track, which is fundamentally focused on wet research, and there really isn't a clinical incentive. The other extreme are the clinician educators who are recruited onto the faculty primarily for their clinical excellence. And while scholarship is encouraged, it's not really mandatory for promotion. And in the middle, there was this clinical investigator path where it's somewhat of a hybrid, where you were expected to be clinically excellent, but you also had to have more than just some kind of scholarship, and research had to be more than just a hobby. You actually had to have some grants to demonstrate a serious commitment in order to be promoted. And the reason why I bring this up is because I was slated for that path, and coming out of fellowship, I couldn't go right into an assistant professorship because I needed to get more training and to develop more of a research background that would allow me to succeed as a clinical investigator, which is why I chose to be an instructor for 3 years. And that was nice because it didn't require me to commit to the clinical demands. The trade-off was I didn't have the typical income commensurate with a gastroenterologist, but I was only really being paid to do 1 day of clinical work. But then the other 4 days I had to continue developing my research interests in pancreatology. So, the trade-off coming out of fellowship was that for the next 3 years, my salary was basically not too different from a fellow, but I also had a lot of freedom to pursue more research. And frankly, in hindsight, I probably could afford to do that because I happened to have a spouse who was also working. So we weren't in dire need of money. So we could afford to do that. And I probably owe her some thanks for allowing me to do that. And then once I became an assistant professor, my salary changed. But I also, with that, I had a bigger responsibility. Now the clock was ticking for me to now be very clinically productive, to start developing leadership nationally in medical pancreatology, as well as to be successful in getting research grants. So that was the path I took, and I've been out. So as I said, I've been out for a little over 8 years now, and I think that kind of answers. I kind of did the brief introduction. By doing so, I'm hoping to give you a little bit of a narrative about how I came to pancreatology. So a little bit of serendipity, a little bit of coincidence, but also I think my interest really stemmed as a third-year fellow. What I acknowledged or realized was that beyond just interest, obviously if you have a genuine passion in the clinical field, that's probably the most important. But if you're like me, I could like almost anything, and I could find anything interesting. What really appealed to me about pancreatology within the framework of GI was that it was a condition that in many ways was often neglected, relatively speaking, when you think about our other members who are in academics or in clinical practice. Most of clinical practice is driven by economic clinical productivity, which is really about general gastroenterology and screening colonoscopies and doing endoscopies, which really drives a lot of private practice. Academically, there are a lot of, the IBD field is very mature. In contrast, I felt pancreas was kind of this neglected condition where there was a lot of nihilism. Well, what could you do? Patients had acute pancreatitis. There were no medications. Chronic pancreatitis, well, those patients were on chronic narcotics. Pancreas cancer, people basically just died. There's a lot of there's nothing to offer. I saw that actually as an opportunity where, the bar was so low that, there was a time in IBD where they didn't have any therapies. They didn't have any monoclonal antibodies. Even before steroids, they were looking at antibiotics. So, and there was a lot of nihilism then. So the way I saw pancreatology was this was an area very ripe for opportunity. And getting back to some of the practical aspects of if you are considering academic career, it's so important to define yourself by being in a clinical niche. And if you look around in many divisions, many pancreatologists de facto are often the therapeutic endoscopist. And it's not that therapeutic endoscopists aren't smart pancreatologists, but it's variable. Many of them, by default, end up being the pancreas person, but they may not have as strong of an interest, and their passion may really lie in the endoscopic procedures. So there still is a need for medical pancreatology, particularly as we further advance our understanding of the pathophysiology, and there are new potential medical therapies on the horizon that are beyond the breadth and scope of therapeutic endoscopists. Not for their lack of interest, it's just that they only have 24 hours in a day, and if you have to keep up your ERCP skills and your EUS skills, you're not going to really just have time to do many of the other exciting things in medical pancreatology. It's just, you know, between your family life and your professional life, there's only so many hours in a day, and you have to make a choice. And that was one of the reasons why I chose not to do ERCP, because I just felt it would take, not that I wasn't interested in it, it just, you have to make choices in terms of how you're going to spend your time.
That's very, very helpful. Thank you so much, Dr. Park. Now, when you mentioned, so when you become an assistant professor, you had mentioned that the time starts to tick and whatnot. Like, what kind of time frame do they give you to apply for grants and develop as a leader nationally before they would consider you as for a promotion?
Yeah, so it's variable. There is no one set rule. It's somewhat personalized, and this is where you have to identify your strengths and weaknesses and have very honest conversations with your division chief or your future employer once you leave fellowship. And you nowadays in academic medicine, there are so many different ways to define your career. So you want to personalize that, and you want to figure out what is it that, first of all, what is it that you want? What is it that your future employer, be it your division chief or department chair, is willing to give you? And what I mean by that is specifically, how much time do you want to spend doing clinical work? How much time do you want to be doing research? Clinical work is the default as physicians, and clinical work, at the end of the day, from the perspective of the division chief and the department chair, while they may have a vision to grow a certain program and they might see you as the leader of that program, at the end of the day, it's not personal, it's business. You have to be able to account for how you're going to pay for your salary. That's, at the end of the day, what matters. So it's very easy for a division chief or department chair to offer a clinical position, which means doing full-time clinical work 80% of the time, 4 days out of a week, because there's no problem there. So long as there's patients and there's a need, the business plan is written. You will see these patients, you will generate clinical productivity, you will justify the salary that you bring to the faculty, period. No problems. The tricky part is when you start discussing and negotiating research time. Research time doesn't pay. And unless you get a grant, research time doesn't pay. So the only way short of a grant is that the division or the department has to either pay for your salary, or in some cases, like the instructor pathway, it's not very difficult for Stanford to support it because they're not really paying me commensurate to an assistant professor. They're just saying, we're only going to pay you for the clinical time you do, but we'll let you stay here and continue to develop your research career. So that's where there is a trade-off. Some divisions and some departments will, because of policy, will say, when you finish fellowship and you join faculty, we will pay you the same we pay all assistant professors. But divisions that have that policy then become stingier about how much research time they're going to give you, because short of grants, every day you're not doing clinical work is a day the division is paying your salary. So the pressure to then get grants becomes higher. That's why it's so important that when you start applying for an assistant professor faculty position, you want to be in the strongest negotiating position, which means you want to have a portfolio of research. You want to make a convincing case that you are someone that the division wants to invest in for a research career. You've published papers, you participated perhaps in writing grants, or you have an idea or an action plan or roadmap about how you're going to get grants. You have a methodology that's going to be unique, that you can write in grants. You want to make yourself believable. You want to convince your department or division that you are going to be able to get that K award or that VA career development award. If you don't have that, your division chief and department chief, as much as they may like you personally, are not going to believe that you are, fit for a research career. And that goes into the negotiation of how much time they're going to protect you up front. A typical package coming out of fellowship for a research career might be 30 to 40% protected by the faculty, by the division, with the expectation that in 3 years, if you don't get that covered, then you have to give up that time and return and cover that time with clinical work. Because the default, again, is they're paying you a certain salary that you're not covering with research time unless you get grants for it.
That was very, very helpful. I think it's especially relevant to myself and Emmanuel and Jamal, who are all looking to graduate from fellowship soon. We have a few people here who are residents who are looking to get into residency and fellowship. Before we move on to other questions, do you guys have any questions that you guys wanted to ask Dr. Park, guys?
Dr. Park, this is Venkat. So why did you not take up ERCP?
Because I think, Venkat, to do ERCP and to do it well and to be truthful to your patients, you have to be committed to it. You have to be willing to do a certain number of procedures per year, right, to keep up your volume, to keep up your skills. And at the end of the day, I looked across and saw all my other colleagues who just loved ERCP. And I just felt I wanted to spend the time that I would have had to spend every year to maintain my ERCP skills. I'd rather be writing a grant, or I'd rather be seeing more patients or doing clinical trials. That was the trade-off I decided. And I realized there are other people who are going to do the ERCPs for me. Not that my patients won't need it, but I'm more than happy to let my other colleagues do the ERCPs for my patients. I'll do the EUSs, and that was my compromise. I learned EUS, but I didn't want to learn ERCP.
So makes sense. So has it been, did it let you be relevant in the business model that you were describing? So when you do not run a wet lab and doing only EUS, so was it relevant in the business model?
Well, yeah, it kind of cuts both ways. On one hand, having more endoscopic skill sets is insurance. It allows you to be more successful when you negotiate your package in terms of your salary. On the other hand, ERCP, as we talked about, you need a certain number of cases to maintain your skill set. And as you know, the indication for ERCP has been declining. We're no longer doing diagnostic ERCPs. And we're really now doing only therapeutic ERCPs. There are only so many people who, my concern with that is, on the other hand, there are many people out there, and if the indications are declining, your ability to get a job will then often depend on being at the right place at the right time, right? Certain high volume academic centers may not need any more therapeutic ERCP doctors. Now, I will say that, the whole field of therapeutic endoscopy is evolving, where there's, being a doctor who only does EUS, I can't do, and not doing ERCP, I can't do a lot of the more sophisticated, complex endoscopic procedures, the rendezvous procedures. But you know what? That's okay. I'm fine, because just like ERCP, to do those, you're going to need to do many of those. And, and there's only 24 hours in a day. And you have to then decide, what is it that you want your strengths to be? What is it that you want to have your career defined by? And I was comfortable not having my career defined by being an ERCP doctor. I wanted my career to be defined by doing something else.
Yeah, thank you. That was helpful to know.
I think it's really hard to know when you're in training, but I think it makes a lot of sense because, as you say, Dr. Park, in order to maintain the skill set, you do need to do a number of them, and with that comes complications, and with complications, it eats up your time, taking care of the complications, and I think it makes sense to use that bulk of time writing grants and seeing patients with pancreatic disorders. So that does make a lot of sense. Now, Kevin and Omar and Eduardo, you guys are in a different stage earlier in your career. Do you guys have any questions for Dr. Park in particular before we move on?
Yeah, I do have one question. So this is Kevin Harris. I'm one of the interns at Cleveland Clinic. Thank you so much for being here with us tonight. My question is specifically, I know you mentioned that you did a T32 training program. I wondered what factors kind of went into choosing that pathway, and where in your career were you when you decided that you wanted to apply for a hybrid T32 fellowship training program?
Yeah, so thanks, Kevin. The T32 is a training grant that you as an individual don't actually apply for. The division that's hosting the fellowship actually applies to distinguish themselves as a research or an academic fellowship. So there's only a select number of fellowship programs in the country that have T32s. So my advice to you is, if you think that you have both the promise, interest, and aptitude for an academic research career in GI and perhaps in the pancreas, then first of all, you want to demonstrate that by trying to be productive on a research level, whether it be in the form of abstracts and getting papers published. So by the time when you apply for GI fellowship and they ask, well, what do you want to do? When you say you might be interested in research, you can back that up. You can say it's more than just talk, and you're walking your talk. And then one of the questions you may have when you apply for GI fellowship is to know, of the fellowship programs that you're applying to, which of them have a T32 program? And you want to inquire what is the program's process by which they select their candidates for their T32 program. And showing that you know what a T32 is, that you have an interest in it, that you want to perhaps be selected for it once you get accepted in the program, shows that you're doing due diligence, that you understand, that these mechanisms exist, and that's how serious you are about pursuing a research fellowship. Now, in my own particular case, once I got admitted into the Stanford GI fellowship program, there were three of us, and then one of us had to be on the T32. The other two were clinically trained, and they first just said, which of the three of you would like to be on the T32? And in my case, my other two colleagues didn't really have as strong of a research interest. They looked in the mirror and they realized their strengths weren't, they did not think they had what it takes to want to pursue a research career, and that they knew themselves, they knew that their strengths really lied in clinical work, and now they're both in private practice in the Bay Area. I still keep in touch with them. But it was very easy then for me to do the T32. It wasn't, in my case, in my year, it wasn't a very selective process. But then consequently, it opened up a lot of opportunities for me.
Thank you.
Okay, before we move on, I think I have a question, Dr. Park. So for these guys that are undifferentiated in terms of what part of GI they want to do, why do you think a resident or an intern or a medical student should seriously consider doing pancreatology as their career choice?
Yeah, I think this gets back to some of my earlier comments. I mean, there's, the beauty of GI is that it is so diverse. The paradox of going into a GI fellowship or pursuing a subspecialty career in GI is that, in a way, you're not really specializing. I mean, yes, you are, but the GI field, unlike kidney, nephrology, and cardiology, is still very, very broad. I mean, it's not just one organ. It's the esophagus, the stomach, the liver, the small bowel, the colon, the pancreas. There are multiple organs involved, and there are multiple kind of conditions. So if you have an interest in autoimmune conditions, well, you can do IBD. You can even do pancreatitis now. You can do, celiac disease. If you're interested in oncology, then maybe you thought, you know what, I really like cancer, but I didn't really want to push chemotherapy. Well, there's so much in the way of GI oncology and prevention. If you have an interest if you were an individual who really enjoyed the nervous system and thought you wanted to do neurology, the whole enteric gut system opens up a whole community of, neurogastroenterologists. And there's so many unanswered questions there. It's so open. If you were deciding between surgery and medicine, and in the end you chose medicine, but after you've done it, you kind of miss using your hands and you really want to take it to the cutting edge, the whole field of therapeutic endoscopy has opened up significantly. So, and then if you're into infectious diseases, you can do C. diff, you can do hepatitis A, hepatitis B. If you're interested in global health, you can still be a GI doctor and travel the world doing hepatitis B trials. So, picking a career in GI, first of all, is not even, in some ways, is not even subspecialized because it's a very broad specialty. Now, within that, it gets back to the pancreas is an area that, needs good people. And it's on the cusp of some exciting opportunities from moving from this nihilism to a lot of unique opportunities. And I think that, it's an area that's underserved and undermet within our specialty. And I think the more we can recruit bright people, the more opportunities there can be. And on a practical level, I think many academic divisions acknowledge that they have IBD docs, they have hepatologists, they have they always need more motility specialists. They have a ton of endoscopists, but they don't really have a pancreatologist. And I think from a job security perspective, if you're thinking about an academic career, pancreatology is an area where, so long as you're interested in it. Now, the tail should not be wagging the dog. You should not just go into pancreatology because to be an opportunist, right? You still have to enjoy the field. But assuming you enjoy the field, there's a lot of opportunities.
Thank you very much, Dr. Park. So moving on, as the next president of CAPER, what are some of the goals that you have in mind that you'd like to share with the trainee committee and the trainees?
Yeah, so CAPER is still a relatively young organization that's still trying to define its purpose. And one of the focuses that we think is unique compared to the many other pancreas-related organizations is that we think we can make a difference in helping develop younger clinicians and investigators in the pancreas. And it has a twofold mission. One is education and one is research. The education piece is about disseminating and training people to develop a stronger interest in the pancreas with a focus on younger individuals. But we've done that more recently in our Pancreas Academy. That is a course tied to Pancreas Fast in the Summer, which historically initially was started on focusing on training actually allied healthcare professionals and pharmaceutical representatives, but has broadened to include all types of practitioners, from nurse practitioners to PAs to residents to fellows to even private practice clinicians, to get the 101 on pancreas physiology and pathophysiology. I'd like to expand that educational mission with some more webinars and CME some webinar opportunities that we're working with our administrative organization pace to develop over the next year or so. We hope our website will continue to be an opportunity for people to access educational materials. On the research side, we want to provide resources that will allow younger investigators to find roadmaps for themselves, find a network and a community of people. And that's where I see the Trainee Committee particularly being a wonderful vehicle to help make that vision a reality. Now, one of the things we want to try to get funding for that we're working on doing so is to try to develop a CAPER Scholar program that combines both our research and education program. And this would try to bring young investigators, a select number of young investigators, to provide a personalized kind of education and research approach that would be tied to mentors over a one-year program. And this is something I hope to see in fruition during my time as president of CAPER, which won't technically start until next July. And I think, so hopefully those are just some of the things. Now, it's still a young organization, and what I mean by that is it still can be defined, and I want it to be defined by the younger individuals, by members such as yourselves in the Trainee Committee. And to that end, you know, we want to empower you, and if you have good ideas about how to make CAPER work for you and how to help you, we want to hear them, and we want to provide resources and support. Now, our budget isn't much at this point. You know, we have like $8,000 to $10,000 in our bank account, so we're not a big organization by any stretch. But if there are ways that we can help trainees get more excited about Pancreas, we are totally open to that. And we hope that as a consequence of having a robust Trainee Committee, we can continue to define what CAPER can be.
Okay, thank you very much, Dr. Park. Moving on to the next question. So one of the trainees asked, you know, how do you stay up to date on the latest pancreatic research?
Yeah, that's a great question, because it gets back to you only have so many hours in a day and life is pretty busy. It's hard. It's a challenge. It's a discipline. And frankly, I'm not as good as I probably should be. The way I do it is, number one, I do go to the Pancreas meetings. So I will go to Pancreas Fest, and I will go to the American Pancreas Association, and I always go to DDW. So that's 3 meetings in a year, which is every 3 or 4 months. And that's one way that I stay on top of the latest research, by looking at the, you know, listening to the abstracts, reviewing the abstracts. I chair the IPMN committee, abstract committee for DDW, for AGA. It gives me an opportunity to kind of see what's out there. I look at the posters, I go to the oral sessions. In terms of the week to week, I participate in a free subscription service called Amedeo, A-M-E-D-E-O. Some of you may know about it. And you can basically, it's free, and you basically just identify what your interests are. You can say pancreas, pancreas cancer, pancreas cyst. And every week, it basically sends me a personalized update of all the publications on those topics. And it's usually about 10 to 15 per week. I don't read them all. I basically peruse the abstracts. I read the abstracts, basically. And then if there's something that is of interest to me, then I download the article. I go to my university website, and I put in the PM ID, and then I download the article to read. So that's how I stay in touch.
That's very helpful. Now, what is your advice for Trainee Committee moving forward, and in order for us to align with the CAPER mission, and what resources? I guess I think you touched on this part of the question. What resources are available?
I think my key advice would be to say, pretend that you are CAPER. You're not just a committee within CAPER. Pretend that you are CAPER. And what I would love to know and want you to think about is, what do you guys need? What do you guys want? What would be great? So when you get frustrated about certain things, write it down, and then bring it to the Trainee Committee to talk about. and see if you can develop actionable ways to help improve the situation. And if we can come up with programs, education, or activities, then we want to know about it and to figure out how we can make your lives make more sense and make it more efficient and make it more easier as it pertains to developing a career, an academic career or a career in pancreatology. And with, no idea is too big or too small. Now, we are limited by our budget, but if you have a great idea, then we can pitch it and we can get them. But one of the things I've learned in this organization is that working with this group called PACE, which is our administrative organization, their whole business model is basically writing grants to pharmaceutical companies to get them to support our educational and research activities. And they're very good at it. And much of what we do at the governing board level is really kind of talk about what are our priorities, and then they write the grant. I basically edit, and review it, and then they submit it to the various pharmaceutical companies, because these companies have educational budgets, basically philanthropy of sorts, and they will provide the money. So it's possible. Anything is really possible with a good idea. And so I'd like for you as members of the trainee committee to not feel like, oh, you're limited by being a trainee. This organization has defined itself by how accessible and it can be to empower trainees.
That's very, yeah. I think it's important to take ownership and continue to stay proactive and creative. And I think we'll continue to do that and hopefully accomplish the mission. And we're actually definitely excited about the Pancreas Scholars Program and looking forward to seeing that come to fruition, and hopefully our trainees can apply for it and get it and get a lot out of it. The last question we have, 3 things, and it's a little cheesy, but 3 things you know now that you wish you would have known as a trainee, as an academic pancreatologist.
Yeah. So I think number 1, keep in mind that your career is 30 to 40 plus years. It really is a marathon. And with that in mind, not everything has to be accomplished quickly. So keep that time horizon in mind. On the other hand, always make goals that are short term, 5 years out, 10 years out. The point of that is, I think there's a certain anxiety that I think that I felt when I was in your situation, where you felt constantly the pressure and by your faculty and your attendings, and to kind of define who you are. What is your 2-minute elevator pitch? Who are you? Are you a pancreatologist? What is your research methodology? What is your focus? And I think for some people who are fortunate, that comes pretty easily. But for many others, it's a struggle, and you're not sure what you know. I would just say be patient. You don't necessarily need to know, but at the same time, be open. Keep your eyes wide open and keep yourself, looking for opportunities. So that's number 1, is just be patient. Don't put too much pressure on yourself. Because many things that do happen that are good for you are going to happen serendipitously. Which gets to the other point of chance favors the prepared mind, which is that as we probably heard since high school through college, but it does. While you don't need to know exactly what you want, so long as you stay in the game, stay focused, stay interested, stay curious, keep looking for opportunities, then chance will favor you. And those opportunities, you'll identify those opportunities. And then, kind of as Woody Allen has said, 80% of success is just showing up. And that's like coming to the meetings, volunteering for the trainee committee, going to Pancreas Fest. When I started out, I felt like there was I felt some anxiety that I was young, but I felt like I was being overlooked, that I had a lot to offer, but I wasn't being recognized. and I felt like I was this angst to try to prove myself. And I think that's, I think what I learned was that the most important thing I did during that time, even though I was feeling frustrated, like I would go to APA every year and listen, and was just that I went, that I kept showing up. And then eventually people in the community, in the Pancreas community, started to realize, hey, this guy keeps showing up. This guy keeps volunteering for things, right? And when you keep showing up, when you keep volunteering, people notice. And then opportunities will arise. And I don't know if there's anything pivotal that I did, or there wasn't a pivotal paper that I published. I just kept going to Pancreas Fest. I just kept going to the American Pancreas Association meeting. And I just kept going to DDW, to the Pancreas section. And it's a pretty small community. And if you go enough, people start looking and realizing that you're a familiar face.
That's actually, yeah, that's very, very helpful and encouraging at the same time. Thank you so much for your sharing candidly what your experience has been. Now, that kind of concludes the questions that we had prepared, but do you guys have anyone have any questions that you wanted to ask Dr. Park before we close today?
Hi, I have a question. Hi, Dr. Park. This is Aisha. Thank you for joining us. So I have a question. I'll hopefully be joining residency this year. So how beneficial is doing GI fellowship before pancreatology fellowship?
How beneficial is it to do a GI fellowship before you do your, so you're saying that you have an option to do a pancreas fellowship before you do your GI fellowship?
Yes, so you can do a pancreatology fellowship in Hopkins without doing a GI fellowship.
Yeah. I think that, I mean, at the end of the day, if you do both, that's fine. And whether you do the pancreas fellowship first or the GI fellowship first, in the long term, it probably doesn't matter. And if your best opportunity coming out is a pancreas fellowship, then a GI fellowship, then do that first. I think that if you can, doing a GI fellowship will give you more perspective when you do a pancreas fellowship. So if you had your choice, I would do a GI fellowship first and then a pancreas fellowship, primarily because you'll have so much more to bring to that pancreas fellowship than if you didn't have the GI fellowship under your belt.
Okay, thank you.
Anyone else have any other questions? Well, it's 9:30. Dr. Park, thank you so much for spending this much time with us. And we just, on behalf of everybody, just want to thank you sincerely for your time today.
Sure. And actually, I want to thank you for being on the call. I mean, you guys, to be on the call, to be interested, this gets back to just showing up. And I really appreciate that. And this is kind of how you take the steps towards being, leaders in your community. Most leadership roles start out as being very much selfless and just taking the initiative. And so I want to commend you all and just again reaffirm that really when I think of what CAPER is, it's really you. It's the trainee committee. That's really what CAPER is. And my role and the faculty who are on CAPER, we're doing this because we believe in the idea that we can make the younger investigators like yourselves who are interested succeed if you have more help.
Thank you very much.
Okay.
That's very encouraging.
Okay.
Okay.
Have a nice evening. Thank you very much.
Okay. Thank you, Dr. Park.
Thank you so much.